Thank you, thank you. So I'm a foot and ankle surgeon, and for me, the biggest kind of thing that I play in my RSD patients is, I kind of have to say it's a little bit of psychology and a little bit of podiatry. Is part of what I offer is a bit of guidance. A lot of patients will come to me, they may not know they have RSD yet, and they may also be looking for, oh, maybe surgery will fix this horrific pain that I have, and unaware that they have RSD. And our job, the way that we look at it in our group, is to help them, guide them through this process. So I was just going to give you some perspectives of what I've learned over the years, because for us as podiatrists, not many guys know about it. Most of my colleagues will go, ooh, I think I have RSD, a CRPS patient. Can you please see them? Because it's like a hot potato. They just don't want their hands on it. So who is a CRPS patient? This is what I've seen. I mean, potentially it's anybody, and you'll see there's sometimes history of depression and other things. But at least in our group, these are people that are internal stressors. These are people that put on a happy face, pretend everything's A-okay, hunky-dory, I can deal with anything. But they're still human at the end of the day, which they've failed to sometimes realize. They're generally the people that can be the rock of the family, that people kind of turn to or count on to get things done when it comes to family affairs. And as I said, they put on that strong face. And inside, they're still human just like the rest of us. And I kind of have my own personal theory. I don't know how true it is, but those internal stressors, we talk about a little bit of podiatry and psychology, is that I feel like they almost have to deal with that stress somehow because it'll want out. It wants out, and anytime I have a patient comes in and they're in a full flare, I go, all right, what's going on with your life? And they'll say, oh, something blah, blah, blah happened, this happened. So there's got to be some level of component to it. Not my area of expertise, but like I said, just what I've seen. So how does this all happen? I mean, everybody here has it. That's why you're here. And so obviously foot and ankle surgery can be one of the reasons that you get it. Can be from any trauma. The simplest and craziest things, as many of you know Heather, and as she might have shared with you, Zumba was in part her downfall. And I told you didn't need that. I mean, you didn't want to listen. Okay. and you see that little cute kitty cat, right? That's the cutest little killer right there. So I had a patient. She was a nurse. Everybody thought she was nuts. She came in, front end of her ankle, really puffy, really tender, purple kind of color. And I go, man, that kind of looks like RSD, CRPS. And I was like, well, what happened to you? Tell me your story. And she said, well, my cat came running across the room and ran into the front of my ankle. And ever since then, it's looked like this, and no one can help me. So even though that cat is cute, felines can be a danger. So just be careful out there. So how do I visually determine for suspicion for CRPS? Is for me, a lot of times it'll be, you have all the other stuff. You can't touch it, you can't look at it funny, don't even smile at it. But the biggest thing is change in color of limb. A lot of patients that I see won't really give you strong details on what they're undergoing. So this patient that you see here is, in essence, I saw her in the hospital. One of my colleagues called me, operated on the left foot, and basically said, yeah, she's got a lot of pain and tenderness. She was already a pain management patient, which is a big kind of red flag for me. Like, you have to be super careful. You're going to operate on somebody, you better have a really good reason. And so I came in and saw her, and I saw that coloration. I was like, I got that kind of, those little butterflies in my stomach that we may have an issue that she's unaware of. So as if this is the same patient, if you look at that incision where I put those little arrows, so you can see that color change. It looks weird. It looks darker than normal, has a purple color. Then you can see her a little bit later where the red arrow is, that's kind of darkened up. These are some of the first things that I tend to see. That when it says kickoff there, another new thing that we've kind of found is that these patients, unbeknownst to them, will hold their foot in a kickoff position, like they're getting ready to kick a ball. And they may stand normally, but if they're sitting, they'll kind of do that, have it sticking out, doing one of these type of things. And that can be one of the first signs that you see. Another patient you can see after bunionectomy surgery, you can see the darkening of the scar lines that are there. You can see the puffiness that's there, and you can see the color changes. This also a nurse, which maybe I should stop seeing nurses because every nurse comes to me seems to always have some sort of pain management issue. I'll refer to my partner. He's better looking anyway. So you can see there that on the left-hand side, this young lady broke her toe, had a small little fracture fragment there. We took out. She called me. She goes, I think I'm having a little reaction. I go, it looks like it, and obviously my patients love to send me photos. And I go, it looks like a reaction to the steri strips. What she failed to tell me is, oh, I re-bumped it again. I'm sorry, I forgot to let you know about that part, which is obviously really important. Because look right here, you can see that kind of darkening starting to happen. And you can see the color change that's there. Now, this patient already had a suspicion, had RSD. She's got one of these fabulous new plans that does not cover pain management, which is awesome for me because I work hand in hand with pain management on what we do to kind of manage patients. So I was already left out in the cold anyway and doing more proximal blocks on her. And I see that, I go, all right, we've got to do something more. All right, so we made the diagnosis. We know what's going on. So what's next? It's obviously CRPS is a team approach. It's not just me. It's just not pain management. It's physical therapist. It's every little aspect that you can bring into it that will help. Use it. And so this young gentleman had a neural injury. You can see the coloration difference between the 2 feet. He also he had a obvious contracture there from the neural injury, but he also would hold his foot in that same kind of kickoff position. So what we did for him, got involved in physical therapy. You know, some patients can tolerate bracing, some cannot. So you can see him in the brace. What this brace does is basically try to hold that foot in that same 90-degree position, which over time with all the standard medical treatment, what we do, physical therapy, you know, he's now back to what we call neutral. So this is an idea of what that brace does and allows normal range of motion across the foot and ankle, but it kind of limits it in some ways to eliminate instability. The other thing, too, with this brace is that it will hold the foot at a 90-degree position and get patients out of that kickoff position. So I put this one in just because as I was writing up this whole lecture, I thought of a patient I had many years ago. And she's Brazilian. She actually used to go down to Brazil for the ketamine treatments. And she was one of those that liked everything really tight on her. Kind of paradoxical for CRPS, but you know, hey, I'm there to help, so I listen to what you like and what you don't like, and then we tailor a plan accordingly. So this young lady, very fashionable, and she loved when we wrapped her legs super tight. So I had this idea, and I don't have a picture, and I wish I took a picture of it, is we made a brace that looks like this, but it came further up the leg. It was one of those kind of like that Greek gladiator look was in for ladies. So we made her one of those binding boots that came up her leg, and she loved it. I don't know how she explained we had one on one side and one not on the other, but it was really, really interesting because it was so paradoxical to the norm, which just brings home the message of just you have to listen to the patient. And if you're not with the practitioner that's not listening to you, you may want to search around, because the biggest thing that I found in helping patients with this disease pattern is listening to what they say and go, okay, how can I take what they're feeling and make that better? So TENS units, these are also effective. It's been around as long as time. You have a vendor here. He can kind of tell you all about it and give you his information so your physician can order it. This is just another tool in the toolbox that you can use to try to help and make yourself better. They come with socks, but depending on if you can tolerate getting the sock on or not getting the sock on. But the biggest thing is using these little the little devices in the right way. And I'll kind of get into that when I get to the topicals. So also what's next? Oral medications. My technique, as we said, is balance the patient's needs with the side effects. So for me, I always use anti-inflammatories. I view this as an inflammatory disease pattern. And so I always have a patient on the level of anti-inflammatories unless something else is going on to where medically it's not appropriate for them. But also an example is pregabalin. It's commonly advertised. Obviously, I can't say any name brands, but you might have seen it. And the biggest side effect is drowsiness. So, you know, if you're a cop, this probably is not very good to take this medication right before you go on shift, right? And probably not a good idea to go, why don't you go ahead and take that first thing in the morning? What would be the smarter thing to do? We know the side effect to it, so why don't we have you take it 2 hours before you go to bed, and you're using the side effect to your advantage. The same holds true for a lot of the antidepressants, which we will use in a way for kind of neuromodulation for CRPS, and a lot of them will make a patient kind of up. So I tell them, treat it like your cup of coffee in the morning. You take that in the morning, you use that side effect to your advantage. And I will mix and match, so I keep everything low dose as I can. And the idea is to try to create a balance without creating a whole bunch of side effects. I don't want someone that's all going, well, I feel better, but I can't function, I can't count to 3 anymore. But thanks, I feel better. That's not really appropriate. We want to have a quality of life, but also to make sure to manage that pain. So topicals, compounding pharmacies, I use a lot of these. Insurances were great with them, now they're not great with them. There's a lot of vendors that will make it for you for a relatively low cost. The idea with this when we talk about tailoring needs is that you want to make sure with the compounding, you can take whatever you want and put it into what I call the witch's brew, which is, I know it's not Halloween, but that's why that's there, is that you're mixing the things that you think would help a patient and you're applying it topically. And these may be medications, if you gave it to them orally, they would be a hot mess. So by putting it into this kind of witch's brew, it tends to work out well. We heard about the cannabis-based creams. That was an excellent lecture. And also kind of a bit of a learning experience for me is as a child of 2 hippies, and the only way I could rebel was to be as Republican and as conservative as possible, is I'm a believer still in cannabis-based creams because I've seen it work on my patients. I've seen it work really, really well. I also seen it work with their stress management, which, as I said before, I think is extraordinarily helpful. So depending on state laws and social taboos, is for patients in this situation, I go, listen, you've got a disease that people want any semblance of cure that they can find. Throw those social taboos out the window. Just use whatever may help you. So when we talked about tailoring patient needs, this lovely little video, you can see on the muscle spasms that are there. So you ask yourself, all right, if I'm making a topical compound, sure, I'll put in the anti-inflammatories and the pain relievers and everything else, but how about a muscle relaxer? And that's the upside of these topicals, is that you can put all this stuff into one big little witch's brew, and they can apply it to over these areas. And it can be really, really helpful. So how do you do this proper application? So if you use this fine specimen of a limb, right here, one of the most beautiful legs I've ever seen. Yes, it is mine. Whatever you do, you got to be careful when you Google stuff. If you Google, like leg or leg without pants, be really, really careful. I thank God I didn't do it around my children, and obviously I made a very appropriate decision just to take a picture of my own leg and use that based upon what I found. So the idea of this is, all right, if I have a problem around my ankle and I want to try to block this issue, is in essence, I've got to hit all the nerves from there and above. So if you look at it, and your medical professional, whoever's helping you guide you through this, can kind of tell you where are the locations to do this. And so I just put a little anatomy there just to give you a rough idea of, in essence, what I'm doing is blocking that nerve cascade as it comes up the leg. And that's the idea. It's the same as if you're getting a sympathetic block, you're just basically trying to block the cascade. And that's how we apply topicals. That's how I tell patients to apply TENS, is it's not necessarily always in the area. It's you want to do it from up above. So also speaking from help from up above is injection therapy from my standpoint. Now, obviously, I'm not a pain management doc. I work very, very closely with them. But when we talk about doing these kind of injections, you would be insane to put it in the area that the RSD CRPS is located. So what I do is we know the area that we need to block. I just block the nerve up above there. This is what I did with that nurse that had no coverage because pain management was optional under her health plan. And this is what I had to do to try to help control her issues. Thank goodness for her, it all worked out. But it's obviously not the ideal way to do it, is that you want to make sure whoever is going to administer this is in contact with your pain management doc. I will normally mandate that my patients have a block prior to even giving one of these. So injection therapy, as we discussed, coordination with pain management, pre-medicating, getting all the medications in order, and discussion of the risks are super important. is you've got to discuss the risk. Obviously, any of the injection therapy that I would deliver in my territory could spark off a new issue up above. And that's why we say you've got to have that whole team approach, and the patient has to know what they're getting themselves into. Everything in medicine is a risk-benefit ratio, and so you want to weigh those out before you make that decision. No, it's not me. I know, it looks very close. I will tell you, and Heather doesn't mind me sharing this with her, is that normally I will give her injections during lunch, or at the end of clinic, when the children are around, because she can make a trucker blush. So, also, what's next? This is kind of new on my own personal horizon with my few kind of RSD CRPS patients of what can we do for them? A lot of times they come to me and they're at the end of the rope as well and go, what else do you have out there? Some patients respond to coblation. Coblation is this high energy field, you get this plasma flow, yada, yada, yada. As I put in there, in English, it breaks down scar tissue and reorganizes into normal tissue. How they initially proved this is they did do some animal experimentation where they took poor little bunny rabbits and they ruptured their Achilles tendons, apply this technology to their tendon where a normal ruptured tendon would have this kind of amalgamous mess of scar tissue. And after they did the coblation, the little bunny rabbits had actually nice, neat, normal tendon tissue. So for our patients that have CRPS and have a lot of scar tissue, and maybe that's a component of it, this is something that we can utilize. Obviously, patient selection is really, really slim, and the patient has to truly understand what they're getting themselves into. So this is kind of a little illustration of pre-op to post-op of using it. The picture isn't as good as I would like, but you can see these little dots right along those areas. And that's where we hit, was right along the scar tissue. And you can see the change from pre-op to post-op. And obviously, you know, it didn't cure the RSD, but maybe it made it better. So what else is out there? Ultrasonic energy tip devices. These type of devices, basically through a small incision, what you do is you break up scar tissue using ultrasound wand with basically ultrasonic guidance. So you can target these little areas. The patient that's up there thankfully did not have CRPS, but she did have a nerve entrapment. I took out a soft tissue tumor. It came back looking exactly the same. Once we took it out, we knew what she had because unfortunately the MRI was wrong on the predictor. So it was basically this amalgamous little scar tissue that normally doesn't form in that area called a fibroma, but that's what she had. So I said, she was doing fine, started getting the neural symptoms. She was like, I'm getting shocks down the top of my foot, and they're coming off to the side. So why don't we use this device to try to break it up? We did it. You can see there's a subtle flattening just right there on the table at the moment of surgery, which obviously as a surgeon, that's awesome because you get to see like what you fixed right then and there. The patient went on to do very, very well and hasn't had those symptoms since. Kind of a combination of the two is that you look at this very young lady, who may or may not be in the audience, and you can see the difference from pre-op to post-op. Not perfect. We still have a couple little areas of concern right there along the scar line, but the scars themselves look better overall. And so this patient had a combination of coblation with the ultrasound, and also she very well understood the risk going into this of what we have. So, oh wait. Did you guys hear it? Sounds gross, right? It sounds awful. So this is, obviously, if you look around the room, you can identify who this is as well. and we've also had this discussion with this patient. The idea of using the ultrasonic energy on her is the same as anybody else. She obviously has an orthopedic issue. You can hear the snapping of the tendon and what that is the tendon relocating back into the gutter that it's supposed to sit in. And it's because it's really, really inflamed. Obviously, nothing else has worked to kind of get it better. So this is something that we could use to suck out the inflammation. So like I said, she has something orthopedically wrong that we could address. And with it, there may be something that's beneficial for this patient. kind of putting it all together. First things first is I want to thank all my patients that are here and family members for giving me the pictures to help put all this stuff together. Every one of you as a patient is different and should be treated as such. The biggest thing is, that I view, is listen to my patient and give them guidance that makes the most sense to me. As a doctor, the way that I view being a doctor is all I'm supposed to do is jump inside your head with your issues and then use my brain to try to figure out what your issues are and then put everything back together. As we said, tailor treatment to the individual's needs, create a balance between mobility and pain management. I encourage everybody here to seek support if you haven't already. Those that are family members, don't be surprised if your loved ones with a CRPS do not want support. This has to kind of happen on their own time. Just be there, be encouraging, leave the door open, and they generally will find the way. The last little part is cry when you need to, but laugh as much as you can, because really I still view that as the best level of medication. Okay? Thank you.